Alright, so this is going to be a brief review for Exam 4 for Biological Psychology. So I have the schedule pulled up here. This is the schedule for my 8 o'clock section. So for that particular section, Exam 4 is going to close at 11 a.m. on April 24th. So that's the end of the final exam period for that section. Let me find the right, out of all my millions of Word documents I've got over here, right one, that's my 8 o'clock section. For my 11 o'clock section, Exam 4 is going to close at 3 p.m. on April 29th, so that's the end of the final exam period for that section. But for both sections, Exam 4 opens at 8 a.m. on April 13th. It's going to be covering chapters 16, 17, and 19. We had to cut out chapter 18, unfortunately, because of, well, spring break being extended and all of that. So, there is a study guide that is posted for you guys on Canvas. So, Exam 4 is going to be the last exam that we have in the class. If the coronavirus situation had not happened, this would have been our exam during the final exam period in class. But instead, this is what we're having to do. So, after you take Exam 4, you will essentially be done in the class. A couple of quick reminders. There is an extra credit for Exam 4 that you can find if you go to Canvas, you go to Modules, you look for material for Exam 4. There's an extra credit assignment there. That extra credit assignment will close at the end of the exam period for Exam 4. So whenever your section's Exam 4 closes, that's when the extra credit closes as well. Also, Activity 12 is going on this week, right? Yes, Activity 12. So if you're happy with the activity grades that you have so far, you need to have 10 activity grades. You can get up to 100 points from activities. But if you've missed a few activities, then completing Activity 12 could be helpful for you. Or if you're just bored and want to complete the activity, then feel free to do that as well. Okay. So this is going to be an overview of Exam 4. It will be multiple choice, true, false, and fill in the blank. I will go in after you've taken the test and check the fill in the blank myself to make sure that Canvas didn't make any errors in grading those. Alright, so briefly, and I do have the slides pulled up over here, close all the things I have over there. Okay, good. Okay, and so it's going to cover chapters 16, 17, and 19. So chapter 16 was on psychopathology, primarily talking about schizophrenia there. So when we talked about core symptoms of schizophrenia, remember that we have positive symptoms and negative symptoms, and that the positive symptoms don't mean good and negative means bad. Positive here is adding. So there's the addition of something unexpected, like hallucinations or delusions, versus negative symptoms where you're missing something that would normally be expected to be there, like a desire to be around other people, emotions, facial expressions, motivation to do anything also. There's also cognitive symptoms. You have a chart of this in your slides, but things like memory problems, attention span issues, etc. Okay. Now, as far as nature versus nurture in schizophrenia, we talked about the prevalence rates, that the average population has a 1% chance of developing schizophrenia, but if you have an identical twin that has schizophrenia, then that raises your risk to 50%. So what that tells us is there's definitely a strong nature component because identical twins sharing genes substantially increases your risk if your identical twin has schizophrenia. However, it's not 100% for identical twins. If it was exclusively nature, then identical twins having the same genetics would have the exact same likelihood of the disorder. So if one of them had the disorder, the other would. If one of them didn't, the other wouldn't. They would always be concordant as opposed to discordant. So the fact that there are some identical twin pairs where one has schizophrenia and the other does not tells us that probably there's a biological predisposition, and both twins inherited that biological predisposition, but then there's something environmental that caused one twin to develop the symptoms the other twin did not. So it's a combination of nature versus nurture. You can find all of that in here about the twins and the rates and discordant and concordant and all of that. Okay, as far as paternal age goes, we do see that there is an increased risk for older fathers to have children that have symptoms of schizophrenia, maybe because as a man gets older, there's more likelihood of there being issues with sperm, the divisions not working correctly, all of that. Differences in brain structures, we talked about a few. We talked about the ventricles, especially the lateral ventricles, and you can see a picture here. So here we have identical twins that are discordant. One of them has the disorder, the other does not. And you'll see that for the affected twins, their ventricles are larger than for the unaffected twins. Okay. Other issues here, we talked about the hippocampus and the amygdala being smaller, and that perhaps there's some disorganized arrangement. So early on in development, when the cells are migrating, something goes wrong there. We also talked about the corpus callosum being thicker and perhaps not working as well. So one side of your brain may not be able to communicate with the other as well. Lobotomies here, and we'll come back to the hypothesis here. We talked about lobotomies. This would be it's a difficult topic in psychology, not something that happens anymore, but the idea behind it was that we think there's an issue with the frontal lobe for schizophrenia, so let's essentially poke the frontal lobe with a stick. I mean, they were using, for some of these lobotomies, something that was similar to an ice pick that they would insert, into the eye socket. Anyway, it's just horrific. But the idea was that they thought they could cure some of these symptoms by damaging the connections between the frontal lobe and the rest of the brain. And although they said a lot of patients got better, you have to wonder if that's not wishful thinking, if that's not cognitive dissonance, like they felt guilty about what they did and tried to convince themselves they did the right thing, or if perhaps they became very docile and quiet, and they took that as a sign of recovery when really it was just a sign of damage. So anyway, as far as theories of the development of schizophrenia, this is where your fill in the blank is going to come from. And so I'd say for that, primarily focus on these different hypotheses here. But there are a couple other points I'll hit with this as well. But the hypofrontality, so less reduction in frontality. So the frontal lobes seem to be less developed. So there's less matter in the frontal lobes, underactivation of the frontal lobes. And so one theory of the symptoms of schizophrenia says that it's an issue with the frontal lobes. You can see that decision-making, parts of attention, communication, all this personality lives in the frontal lobe. So it would make sense that an issue with the frontal lobe could cause some of these symptoms. This belief is probably related to where lobotomies come from. All right, but probably the most prominent hypothesis, the dopamine hypothesis. This is what the extra credit for exam 4 talks about. So the big picture idea is that dopamine, this neurotransmitter, seems to be overactive in individuals who have schizophrenia. That's the hypothesis anyway. So we have too much dopamine, or the dopamine receptors are overly active, and so because of that we have symptoms of schizophrenia. Now, I don't want to just give you the answer for your extra credit. The extra credit asks you to think about evidence for or against, but I do encourage you to make sure that you understand that, thinking about how Parkinson's disease and schizophrenia are on a dopamine spectrum. So with Parkinson's disease, you don't have enough dopamine, and so you have movement-related symptoms. With schizophrenia, you have too much dopamine. So then if you take an individual with schizophrenia and give them treatments to reduce dopamine, you can drift too close to the Parkinson end of things and end up producing movement-like symptoms. If you take a person who has Parkinson's disease and you increase their dopamine, give them L-DOPA, the precursors to dopamine, you can go too far and start to cause some symptoms that resemble schizophrenia. So we have some evidence there. We also have some evidence related to how, especially the first generation or typical antipsychotic drugs worked, but we also have some evidence against the dopamine hypothesis, the idea that the change happens very quickly with the drugs, but the benefits don't show up, the symptom reduction doesn't happen right away, that kind of thing, okay? So that's what I'm looking for in the extra credit. So the dopamine hypothesis is in a large part based on first generation typical antipsychotics. We also have second generation atypical antipsychotics that some of them work on dopamine as well as serotonin. Okay. The glutamate hypothesis could be related to the dopamine hypothesis. The idea behind the glutamate hypothesis is that you have an underactivation of glutamate, and so perhaps there's been some suggestion that having overactivation of dopamine could cause an underactivation of glutamate. So these two could be related to each other. But when you have drugs that are antagonists of glutamate, then you can cause some symptoms that look like psychotic disorders. However, it's difficult for us to use this information to treat schizophrenia because when you try to increase the activation of glutamate, and glutamate is an excitatory neurotransmitter, then you could create some, why is my brain not working today? You could create some seizure issues, like when your brain becomes excessively active, that kind of thing. So you want to be very cautious with that. Okay. And then primarily this chapter talks about schizophrenia, but also bipolar disorder, having symptoms of mania and depression. So periods of high and periods of low. And we talked about how there are some more mild cases. Oh yeah, this as well. One other thing, sorry, back to schizophrenia. You want to take a look at some of the environmental risk factors as well. So the fact that people who are born in the winter months are more likely to develop schizophrenia. There's a correlation between prenatal exposure to the flu and schizophrenia. People who live in city areas, especially large cities, have a higher risk versus rural areas having a lower risk. That kind of thing. So just take a look at that. But yeah, so bipolar disorder is typically something that we think of as an individual having symptoms of depression and having symptoms of mania. It is possible that a person could have symptoms of depression and then hypomania, so having a less severe form of mania. Also, it is possible to have cyclothymia, where a person has hypomania, so a milder form of mania, and dysthymia, which is a milder form of depression. So here the symptoms might be more mild, but they could also be more chronic, longer lasting. Lithium is a mood stabilizing drug. Bipolar disorder is one that, like schizophrenia, it seems to be highly genetic, highly biological. Usually you have to have a drug in place. Therapy is really helpful, but usually you need a drug treatment. A mood stabilizer in particular, lithium tends to work really well. But the danger of lithium is that it has a very narrow therapeutic window. So that means that the distance between the dose that is effective and the dose that is dangerous or lethal is not a very wide dose. So you have to be very careful if a patient's taking lithium. Okay. Symptoms of depression. So we had anhedonia, which is a loss of pleasure. That's something that you can find in bipolar disorder because you have symptoms of depression, but also with schizophrenia as well. So anhedonia, loss of pleasure, depressed mood as well. And then other symptoms, people feel tired, people have a change in appetite, thoughts about hopelessness and helplessness and that kind of thing. You do tend to see some biological differences in depression, so we do think it's at least partially due to biology, at least in a lot of cases. Increased blood flow to the prefrontal cortex and amygdala, so a lot of thoughts, hard to turn your brain off, a lot of negative thoughts, especially related to the amygdala, and then decreased blood flow to other parts of the brain, increased blood flow to parts of the brain that might produce some negative symptoms there. One thing to think about with treatments of depression, therapy is a great option, but this is not a behavior modification class or a therapy class, so your textbook focuses on biological treatments. So there are different types of drugs that are listed here, and you have a chart that talks about those. One thing to remember is that with electroconvulsive therapy, this is still happening today. It's not happening in exactly the same way that it used to happen. It's gotten a lot safer and a lot less aversive for the person to experience, but sometimes an individual might have symptoms of depression that don't go away with other standard treatments, and so electroconvulsive therapy, where you're essentially triggering a small localized seizure in the brain, can help. Of course, there are side effects, but it is still being done today. Not as a first-line treatment. Good. Okay. Okay, the thought is that a lot of the research has suggested there's a monoamine issue. So you have a problem with things like dopamine, serotonin, norepinephrine. So a lot of the treatments for depression are medications that are intended to increase the effects of monoamines. Good. Remember how we talked about anxiety disorders, about how PTSD and OCD are in a different category now in DSM-5. PTSD is in a stress and trauma related category versus OCD is in a like obsessive compulsive, its own little category that's more about behavioral control, like focusing on the compulsion side of things, which I don't know if I agree with as a person who has OCD. I feel like my particular brand of OCD is more obsession than it is compulsion, at least these days. But that's where they decided to put it. Nobody asked me. That's fine. I'm not the expert. So they are not in the anxiety disorders category in DSM-5, but we do talk about them a little bit here. We talked about PTSD and how it's related to fear conditioning, about how you can become classically conditioned to be afraid of something new, and how that can cause phobia, it can cause issues related to PTSD, like if a person is traumatized in a particular location, there's a particular smell, there's a particular noise, you can become conditioned to be afraid of that, and how the amygdala is involved. Good. Right. Remember with OCD, you have the obsession, that would be the thought process, something that it's hard for you to stop thinking about, that causes anxiety and distress, could be an image, could be an idea, etc. And then the compulsion is something, whether it be overt or covert, like are we acting it out where everybody can see, or is it internal, something we're doing in our mind? A compulsion is something that will try to help you reduce the anxiety from the obsession. Okay. So, chapter 17 is on learning and memory. So, I want you to understand a little bit about each of the case studies. So, we talked about HM, about how he had seizures that were not responding to treatment, and so they removed the amygdala, the hippocampus, and some of the cortex from his temporal lobes. And because we were able to compare this with others who've had similar but a little bit different procedures, we narrowed it down to, it was especially the hippocampus that was the issue for HM's memory. So because of this, he was not able to form new long-term memories after his seizures, or after his seizure surgery, right, which removed his hippocampus. So what we have here are the two different types. Retrograde amnesia refers to the loss of memory from before the incident, which is not uncommon for a short period of time, like to lose the hours or the days beforehand, but to lose everything is pretty rare if it's ever happened at all. But mild retrograde amnesia after surgery or an accident is not that uncommon. Anterograde amnesia is very rare, though, and that's what HM had. He was not able to form new memories, although he was able. Okay, he wasn't able to form new declarative memories, but he was able to form new non-declarative memories, procedural memories, skills. He learned how to do better at this memory, or this motor skills task here, where he was asked to look in a mirror and do this tracing activity. And even though he didn't remember having done the task before, he had no declarative memory of the experience, his motor skills did improve. So he was still able to form new memories that were like procedural, but not declarative. Okay, good. And once again, I'm hitting the highlights here. If you have questions, let me know. Remember that recollection is the specific details of where have I seen this before, when have I seen this before, versus familiarity. I know I've seen this before, but I don't remember exactly when or where, and so those are covered by different parts of the brain. Okay, NA was the unfortunate individual that was fencing and had the fencing sword thingy go up his nose, and he also had anterograde amnesia like HM, but his hippocampus was not the part that was really damaged. He had parts of his thalamus and hypothalamus, so that's the diencephalon, parts of that were damaged, and his mammillary bodies, okay? So they damaged the connections between the different memory-related structures. So we lost the connections between the mammillary bodies, the hippocampus. Remember that hippocampus is Latin for seahorse, and the mammillary bodies are sort of like the tail on the seahorse. I don't know if that helps you picture that. Okay. Very good. Korsakoff Syndrome is an issue that usually comes up in people who abuse alcohol, because if they are abusing alcohol, they're not getting a balanced diet typically. And so there's thiamine, which is vitamin B1, I believe. If you don't have enough for a substantial period of time, then you can start to have symptoms of Korsakoff Syndrome that you may not be able to bounce back from. So then there has been the suggestion that maybe we should fortify alcoholic beverages with vitamin B1 to try to reduce this risk. So what happens here is that you have brain damage in the thalamus and the mammillary bodies, so memory-related areas, but also there's damage to the frontal cortex. And the thought is that this damage is what causes the confabulation, where they make up stories that they seem to believe that are obviously not true. And that's not something that happened with HM or with NA, but it's something that happens with individuals who have Korsakoff Syndrome because we believe because of the damage to the frontal cortex. Okay, good. Casey was the patient that we talked about that had a motorcycle accident. And after that, he had an issue with episodic memory. So now we break declarative memory, memory that you can talk about, into semantic and episodic. Episodic would be the personal stories of your life, right? There I go again with the One Direction songs. I miss you guys. I haven't been able to complain about my toddler not sleeping. But anyway, if you don't get that, that's fine. Just move on. So what we said here is that episodic memory would be, what did you do on your last birthday? Or tell me about your high school graduation, that kind of thing. Versus semantic memory, that would be like the presidents and the state capitals and that kind of thing. So he was able to retain his semantic memory, but he lost his personal memories. And so that tells us that they must be stored in different locations, because he retained one and lost the other. Okay, good. Let's see. Right, so types of memory here, if we go, there's a chart. That's not the most updated chart. We go down here. Okay, so we have, and you could also have another little bar out here with sensory memory. Don't forget about sensory memory. So the way that this works is that information comes in through your sensory memory, all the information in the environment. It's held there for a very brief time. So there's a short duration, large capacity. A lot of information held for a brief period of time, but then most of that is discarded. It's considered unimportant, but then whatever you pay attention to gets into short-term or working memory. And then you can keep something in short-term or working memory for a few seconds, up to maybe 30 seconds, or indefinitely through rehearsal. If you just keep repeating it to yourself over and over again, then you could remember that until you get distracted, or maybe until you fall asleep, that kind of thing. Okay, and then long-term memory, so you take the information and you practice it, and you make new connections with it, you do something with it, and hopefully it makes it into long-term memory if this is something you're trying to learn. Long-term memory breaks down into declarative. Those are the memories you can tell someone about, versus non-declarative. That's more of like showing your memory there. Declarative breaks down into episodic, the personal stories of your life, versus semantic, which would be general, factual knowledge, vocabulary, etc. And then non-declarative memory could have skill learning, so like the mirror tracing task or playing a musical instrument, perhaps, that kind of thing. Priming, where earlier exposure to a stimulus changes your response to the stimulus later. Like if you've been showed the word stamp earlier, and then later you were shown STA and asked to finish it to make a word, you're more likely to do stamp than you would have if you've not been exposed to stamp earlier. So that's priming. Classical conditioning, which I can go back and go over in just a second. And that's really what you want. We're going to talk about non-associative learning with the slug situation in a second. But with classical conditioning, you have your unconditioned stimulus naturally causing your unconditioned response, no learning needed. And then you take something that's originally neutral and pair it with the unconditioned stimulus. Ring the bell, give the food. Ring the bell, give the food. The dog will learn that the bell means food is coming. The dog will learn an association here, so that then when the dog hears the bell, the dog will have a conditioned response of drooling because he's learned the association between the bell and the food. Okay. Let me know if you have any questions about that. The serial position effect is the idea that you tend to remember the things at the beginning and the end, and you lose the things in the middle, unless the things in the middle are especially distinctive. So you see the primacy effect here is remembering things at the beginning of a list or at the beginning of a lecture, that kind of thing. Recency effect would be at the end of the list, end of the lecture, that kind of thing. Okay, so yeah, I think we've covered all of that. Encoding, consolidation, retrieval. You've got to get information in. You've got to be able to move it then from short-term memory to long-term memory, and then you have to be able to use it. And the thought is that every time you retrieve a memory from long-term memory, you probably change it a little bit while it's in working memory. And so we can use that to our advantage when we're treating PTSD. We can take an individual who has a traumatic experience. We can have them remember that traumatic experience while they're under the influence of a substance that blocks epinephrine, so they will feel more calm while they're thinking about it and discussing it, and they'll save that calmer version in their memory, or at least that's the idea. It does seem to be pretty helpful. As far as synaptic changes with learning, we talked about long-term potentiation, the idea that the neurons that fire together wire together, so that when you have some type of learning, you might have more neurotransmitter released, or you might have more neurotransmitter, or you might have an increase in the number of receptors, or you might have more neurotransmitter and an increase in receptors. You might have other neurons becoming more active, which will then cause more neurotransmitter to be released. Or you might have new connections that are forming and old connections being pruned. So all of these things that are happening in the synapse can be the result of a learning experience and could be the basis of neuroplasticity, right? We talked about with lab animals, keeping them in different conditions, and that there were certainly advantages for the lab animals that were kept in enriched conditions. It talks about a heavier, thicker cortex, so probably having more brain matter, increased neurotransmitter activity, especially acetylcholine, which is related to learning and memory, more connections. So it's not a very far stretch to say that this is probably true for humans as well. At the end of this set of slides, we talked about how people who exercise, people who have people around them they can have high quality intellectual conversations with, all these things can cause a person to be less at risk for cognitive decline. Okay, the main idea with the aplysia, with the sea slug, is that even though it's a very simple structure, a very simple animal that has a very simple nervous system, we can still see learning here. We talked about how if you're spraying something on its siphon, is that correct? The siphon, right? Yes, the siphon. If you spray something on the siphon, it scares it and it retracts its gills. But the more you spray on the siphon, it learns that it doesn't need to be afraid. This is not going to damage my gills. And so the gills are retracted less. And so that is a simple form of learning, but learning that's still happening here in a very simple structure, very simple animal. Okay. And then long-term potentiation, basically we're talking about an increased effectiveness in neurons that happens as they fire together. And the thought is that this is likely, and there's a lot of evidence to suggest that this is part of how learning happens. We know that the long-term potentiation is something that happens quickly after a learning experience and lasts for a while. We know that if we block the LTP, that can cause an individual not to be able to learn. And if we teach them something, we can induce LTP. So at least there's correlational research to say that long-term potentiation is related to learning. Okay, and then our last set of slides on chapter 19 was about language and lateralization. So when we talked about lateralization, we're saying that there's specialization between the left and right hemispheres, not that you are left or right brained, but that for most people, the left brain, the left hemisphere, is more involved in language tasks versus the right hemisphere that's more involved with things like faces, shapes, spatial representations, directions, that kind of thing. Now, a lot of this research has come from split brain individuals, so you can see the pictures here. This is a very rare situation in people. They do this research in lab animals, but some individuals have their corpus callosum severed because of seizure issues. And so the corpus callosum is the connection between the left and right hemispheres. So once you split the corpus callosum, it's very difficult for the left and right hemispheres to communicate with each other. So what we find here is that the information from your left visual field is sent to your right hemisphere of your brain. And the information from your right visual field is sent to the left hemisphere of the brain. For healthy people, it doesn't really matter a whole lot, because as soon as information is sent to the right hemisphere, it's shared with the left and vice versa. But for someone who has this split brain procedure done, if they have information sent to their right hemisphere, it's stuck there and can't get to the left hemisphere. And since most people have their language centers in the left hemisphere, you might not be able to think of the word for even a very familiar item because that information can't get to the language centers. Okay. We talked about how oftentimes this research has been done with individuals who have had this procedure, that individuals who are born without a corpus callosum usually have less severe symptoms because this is something that happens early in development and the nervous system is plastic and able to compensate for that, which is really, really incredible. The right ear advantage, information coming in through your right ear is going to be sent to your left hemisphere. Information coming in your left ear is going to be sent to your right hemisphere. And since most people have their language centers in the left hemisphere, most people have a right ear advantage. So if you have a dichotic presentation, you have two different sounds being played in your ears at the same time through headphones, then the sound that's coming in through your right ear usually has an advantage because it gets to your left hemisphere more quickly. But this only happens when you have that dichotic presentation, so a different sound in each ear, and when those are consonant sounds versus vowel sounds where you don't see the same advantage. Maybe the vowel sounds are not as distinctive from each other as consonants, perhaps. I'm not sure exactly why that happens. The tachistoscope, there we go, tachistoscope. I'll get it in a second. This is just kind of continuing on with that research, showing that if you can get information into the right visual field, it will be sent to the left hemisphere. And if you put information in the left visual field, it goes to the right hemisphere. So when you put information in the right visual field and it's sent to the left hemisphere, for most people that's where the language centers are located. And so language-related tasks will be more efficient if you can get it into that left hemisphere first. Versus the right hemisphere, which information comes from the left visual field into the right hemisphere, where, as I said earlier, you have better recognition of faces, shapes, spatial reasoning, etc. Okay, good. WADA test. Here we go. So we talked about with the WADA test, you have anesthesia that numbs essentially one hemisphere, sort of like mimicking a stroke for a brief period of time. And so what you'll find is that for most people, if you anesthetize or numb the left hemisphere, they'll have issues with language because for most people, that's where the language centers are located. If you anesthetize the right hemisphere, then language is usually not impacted, but you will have symptoms like the right side of the brain controls the left side of your body, that kind of thing. We saw that this is especially true for right-handed people, that their language centers tend to be on the left hemisphere, although it's also true for the majority of left-handed people, but there are some left-handed people that have language centers in both hemispheres, and there are more left-handed people that have language centers in their right hemisphere than do right-handed people. Good. As far as different disorders, prosopagnosia was one that we talked about. Bilateral, so both sides of the fusiform gyrus being damaged, causes complete prosopagnosia, where the individual cannot recognize faces, even their own face. It just doesn't mean anything to them, the differences in faces. Although they can still recognize differences in like tone of voice, that kind of thing, faces just don't mean a whole lot. And so they might not even recognize their own face at all. And what they do to research this is they do that WADA test where they anesthetize different hemispheres. And they find that if the right hemisphere is anesthetized, which is involved more in facial recognition, then it's harder for a person to see aspects of their own face in a composite picture. So the right hemisphere is more related to being able to recognize faces and shapes and things. The fusiform gyrus, now this picture, what they've done here, this is the bottom of the brain, right? And so what they've done here is they've removed the cerebellum so that you can see a little bit more clearly. So normally the cerebellum would be right here. But you have this fusiform gyrus, which is this area on both sides. That's especially important for facial recognition. All right, types of aphasia. So table 19.1 is a good one here. So we talked about how you can have paraphasias, which is not on this table, but it's just more mild symptoms of aphasia. And then if you have a full-blown aphasia, different types, non-fluent or Broca's aphasia happens when Broca's area is damaged. Broca's area in the frontal lobe that's important for speech production. So an individual might still comprehend everything that they're hearing, and they know what they want to say, but it's very difficult for them to produce speech. Versus fluent aphasia or Wernicke's aphasia, where Wernicke's area, which is in the temporal lobe and then could also include some areas in the parietal lobe, that's damaged, and so it's hard for that person to comprehend what other people are saying to them, and they're able to produce speech fluently, as in they can talk easily, but the words that they're using often don't make sense. Global aphasia only happens when you have large damage to lots of different areas, large areas of damage in whichever hemisphere your language centers are located in, which for most people is in the left hemisphere here. So you may lose really all language-related skills with that. With conduction aphasia, you have difficulty repeating. So you can understand what people are saying to you. You can speak just fine. But if someone says something to you and asks you to repeat it, then you struggle a good bit with that. The thought with conduction aphasia is that an individual has lost the connection between Broca's area and Wernicke's area, that arcuate fasciculus, which is important for that connectionist model of aphasia. So the connectionist model of aphasia, and here's somewhere, here we go, the idea that you have to have not only the functioning language centers, but also functioning connections between them, that the arcuate fasciculus connects, or may connect, Wernicke's area and Broca's area, and that if that area is damaged, a person's not able to repeat what they've heard. However, you have conduction aphasia as evidence for the connectionist model. You have this arcuate fasciculus as evidence for the connectionist model. But then a problem is that for most people, it doesn't really connect Wernicke's area and Broca's area. It gets close, but it doesn't quite connect. So because of that, there are other models as well. Sensitive period for language, remember that the first few years of life are when an individual is most likely to be able to acquire language easily, and that if you get to a certain point and an individual has not been exposed to language, then serious consequences can arise because of that. We talked about dyslexia. We talked about my dislike for the term dyslexia. I apologize for my voice. I lost my voice the first spring break, I think it was. Like, you guys might remember I was croaky the last lecture day we had before spring break, and I completely lost my voice for like a week, and that was fun. Parenting without a voice is hard. And we had to listen to audiobooks. I couldn't read to my kids. But anyway, ever since my voice came back, I get croaky, especially when I've been talking for a while. So I'm sorry. I apologize for that. I may always sound like this now. Anyway, so types of dyslexia, we talked about the fact that I don't like the term dyslexia because it's not in the DSM-5. The DSM-5 would call this specific learning disorder with impairment in reading, but your textbook uses the term dyslexia, so because of that, I am going to use dyslexia. Okay, but you know how I feel about it. All right, good. So dyslexia in general would be a specific learning disorder with impairment in reading. Now, we talked about a couple of different types, how deep dyslexia has more to do with semantic meaning of a word versus surface dyslexia having to do more with the phonics rules and about how English is a rather complicated language that has a lot of exceptions to phonetic rules. So because of that, languages that are more phonetic might have fewer cases of dyslexia that are involved. Okay. Last thing here, hemispherectomy. We talked about how it is possible that an individual might have to have an entire hemisphere of their brain removed. This particular x-ray here is looking at a little girl. She was 7 years old and having severe seizures that weren't responding to any other treatment. So they decided to remove the hemisphere where the seizures were being produced. And although she did have some symptoms, paralysis, loss of speech, etc. at the beginning, her brain was able to compensate for that. So the big picture idea here is that your brain is amazing, that it's able to recover a lot, but that the sooner the damage, the better, that when damage happens in kids, there's a surgery, there's an injury, etc., their brains are much more flexible than in adults. Even though your adult brain can bounce back to a certain extent, it's going to be a lot more difficult because it's not as plastic. Okay, good. All right, so that's the end of the study guide. If you have any questions about any of this material, please let me know. I have enjoyed teaching you guys this semester. Let me know if there's anything I can help you guys with in the future, and I hope that your semester wraps up very easily and smoothly and that you have a great summer. I'll talk to you guys later.